Perfect. So I'm going to be talking to you this evening about what is laminitis and what causes it. We will cover what is laminitis, how to spot it, and the causes of laminitis. So most of you will have heard of laminitis, and many of you will have had first-hand experience with managing the condition. Laminitis is sadly a very common, very painful, and often recurrent conditions of horses, ponies, and donkeys. It affects the attachment of the hoof wall and the distal phalanx, otherwise known as the pedal bone. The attachments are called the laminae or the hoof lamellae. It is important to remember it's not just a condition of chubby ponies in spring and autumn. It can affect any horse at any time of year. It's a very serious welfare concern. Over 7% of equine deaths are linked to laminitis, and I think that probably is a slight underrepresentation. To understand laminitis, you need to first understand the laminae. So they are the attachment between the hoof capsule and the pedal bone. And it's an interdigitation of the dermal and epidermal lamina, which form a bond between the hoof capsule and the pedal bone. A simple way to think about it is they slot in between each other like your fingers. They act to support the weight of the horse and also against the pull of the DDFT, the deep digital flexor tendon, that attaches to the back and underneath the pedal bone. The laminae run the whole way around the foot, including the bars, heels, quarters, and the toe. Think of the epidermal lamina as being an extension of the hoof capsule and the dermal lamina as being an extension of the pedal bone. So you have primary epidermal lamina, which you can, I don't know whether you can see my mouse. So there is the pink structure here. And you have dermal lamina attaching to the pedal bone. And projecting off these, you have secondary epidermal and dermal lamina accordingly. To give you an idea of numbers, there are 550 to 600 primary epidermal lamina, and on each of these, there are 150 to 200 secondary epidermal lamina. So it's a very complex, almost organ in its own right. So you can see on the image on the left that you have a sort of cross section of the hoof wall, and starting with the outside of the hoof wall and coming into the lamina, which are these sort of feathery-like structures down here. On the right of the screen, you can see a histology slide, and the primary epidermal lamina are labeled as the star, and the secondary epidermal lamina are labeled with these little black arrows. So now we have an understanding of what the laminae are. We can discuss their role and their dysfunction. Laminitis is defined as inflammation of the hoof lamellae and the hoof lamellae or lamina. This is an incredibly painful condition. During an episode of laminitis, no matter what the cause, there is a loss of strength of the lamellae attachment due to morphological changes in the lamella. The pedal bone is no longer suspended appropriately within the hoof capsule, which leads to sinking and rotation of the pedal bone away from the hoof wall. This can be seen on X-ray, radiographically or on X-ray. If the pedal bone rotates away fully or rotates fully, it can penetrate the sole of the hoof, which is called founder, and that is sadly a life-ending complication. So we've got two histological slides. So they're slices of the lamina that we'd look at under the microscope. The images are on the left, a section of lamina from a non-laminitis prone horse. The secondary epidermal lamina, which are the sort of the projections off, so they look like it looks a little bit like a feather. So they are uniform and they have rounded tips, which you can see down here. The tips of the secondary dermal lamina, they extend deeply within the gaps between the secondary epidermal lamina, and they go in close to sort of the main body of the lamina, the primary epidermal lamina. The images on the right are the morphological changes seen in a horse with laminitis. And the secondary epidermal lamina, you can see they're no longer uniform, they're stretched, they're long, and they're pointy. So on the image on the left, you can see the front of the pedal bone is parallel to that of the hoof wall. Whereas the image on the right, is, you can see, so this is the hoof wall, where the hoof wall is, and that is the angle of the pedal bone. And you can see how the pedal bone is rotated away from the hoof wall, and it's on its way to penetrating through the sole. Oh, let's come back again. Sorry about that. It's so important to recognize the early signs of laminitis. If caught early, the recovery period should be swifter and the severity of the condition should be less. It could be as simple as a change in behavior or a change in temperament, a shortened stride, stiff gait. This doesn't always look like a lameness. So if a horse or pony is uncomfortable on either both its front feet or both its hind feet, or even all of its feet, you don't necessarily notice a lameness, but you will notice a change in their way of going. Your pony might not be as willing to have its feet picked out. Often people just think they're being awkward, but it might be because they don't want to have all of their weight on the opposing foot. There might be a slight reluctance to turn if your horse takes care on hard or stony ground, or often they might take you towards soft ground. There might be a mild increase in digital pulse or abnormal heat in the hoof wall. These signs can be really subtle, and Natasha is going to talk to you about pain scoring in her next talk. The more classic signs of laminitis: horse not wanting to pick its feet up, weight shifting at rest, lameness, pottery gait, especially on a firm surface. Often you might describe it as a cat on hot coals. They're not quite sure which foot they really want to be bearing weight on. Trying quickly to shift weight from one foot to the other. Bounding digital pulses. So on the image on the right, you can see I've got a blue circle, and that's around where I would feel for a digital pulse. So you should feel something stringy running under the skin, sort of flicking under your finger and thumb, and they run down the side of the back of the fetlock over each sesamoid bone. So rest your finger gently on these areas, and you should feel a slight pulsation in the normal horse. But in a horse with laminitis, it'll often be sort of quite a bounding pulse or a bounding pulsation. It's good to know what's normal for your horse, and also to get practice actually feeling for a digital pulse. Sometimes horses they can even be sensitive just with pressure on the sole, and it doesn't always have to be pressure with hoof testers. It can just be digital pressure with your own hands. Last one, lying down. You also need to be careful whether you see if your horse is colicking, if your horse is so uncomfortable that it's lying down for laminitis, but that can also be confused with a horse colicking. So laminitis can occur in the hind feet as well as the front feet. Front feet is sort of a more classical laminitis that most of you will be looking for. So laminitis, when they're sore in their hind feet, they, in my experience, have adopt this more elephant on a drum type stance rather than rocking backwards off their front feet. So once my pony has had laminitis, will it keep coming back? Yes, it is more than likely that it will reoccur unless the underlying causes have been addressed. So risk factors for laminitis. Age is not a strong risk factor, but older horses are more likely to get laminitis. Breed, so native ponies, are more likely to have endocrine disorders. Obesity, these individuals are more likely to have insulin resistance and insulin dysregulation. PPID, which is equine Cushing's disease, or a previous history of laminitis. Whether this is due to these risk factors for laminitis not being fully addressed. Clinicopathology, so that's things that we test for. So we look for insulin resistance or hyperinsulinemia, dyslipidemia, and abnormal adipokines. External factors, so dietary excess, season, spring, increased quality of grass or autumn, you do get an increased pituitary activity in PPID individuals, or also a low level of exercise. So what risk factors can be investigated and controlled? So obesity. You subjectively look at your horse, or your vet will help you, and whether body condition score, weight taping. PPID, so we look at the basal ACTH, so that's the blood sample we take to test for Cushing's, or a TRH stimulation test. Insulin resistance or hyperinsulinemia, we generally would recommend an in-feed glucose test. Low levels of exercise is subjective. Is your horse doing work? Is it in work at all? Can your horse cope with doing any more? Dietary excess, over 2% body weight per day, or over 127 kilojoules per kilo per day. And controlling these factors will be discussed in the next talk. So diagnosis is based on history, looking at the risk factors that we looked at in the last slide, a clinical examination, an action exam, watching how the horse moves, palpation, so feeling for a digital pulse, and also using hoof tests, whether your horse or pony is sensitive, especially around the toe, or even just with light percussion with either a hoof pick or our hoof testers. Radiographs, you can see these x-rays from a normal horse. You can see that the pedal bone is parallel to the hoof wall, and the image on the right, you've got that rotation away from the hoof wall and sort of long slippering of the toes. And also lab tests, but that's when we're looking for identifying other risk factors. So here you can see this is a very chronically laminitic pony. You see this bulging of the hoof wall at the front here, and that the pedal bone has rotated away from the hoof wall. Got some gas shadowing here, which is indication of laminar separation, and slippering at the tip of the pedal bone, and that's a chronic change, so indicative of chronic laminitis. These are x-rays from a horse I had been looking after, and the first image is actually just 1 day post onset of acute laminitis, and he doesn't necessarily have rotation, but you can see that the tip of the pedal bone, and actually the pedal bone is quite close to the shoe here. So actually this horse had begun to sink even within a day of the onset of acute laminitis. And you can see he's got pads on here that I'd placed that night. And then the next day he was a lot more comfortable. So then the next image is 1 month afterwards, and he had stabilized. The x-rays hadn't changed a great deal, but he was a lot more comfortable. I thought we were winning the battle. And unfortunately, then 2 months later, he went very sore again. And you can see that the pedal bone has slightly rotated, but has sunk very, very close, and was about to come through the sole of the foot, which was very sad. This next image was actually of a pony I saw this morning, and it's just a really nice, so it's about 5 months since the first episode of laminitis, and he is now very comfortable, and he's off pain relief, but we haven't yet put him out on the grass quite yet. But I met the farrier to take some follow-up x-rays, and you can see how at the sides here, nice, more normal foot, but towards the toe, you can see the hemorrhage or bruising and the real stretching of the lamina. So the right foot, which is the one on the right, is worse than the left. So types of laminitis, so sepsis-associated laminitis, grain overload, supporting limb laminitis, and also endocrinopathic laminitis, so PPID, EMS, or glucocorticoid-induced laminitis. So sepsis-associated laminitis generally is associated with gastrointestinal disease, or often colitis, diarrhea, pneumonia, or septic metritis, which can be seen in mares that have retained their placenta longer than we would like, and that hasn't been dealt with by a vet, and we haven't removed that. So the sepsis or / generalized inflammatory state lead to lamellar failure. The exact pathway isn't fully understood. The basic cause of lamellar failure in laminitis is the failure of the attachment of the epidermal lamina to the underlying dermal lamina. So inflammatory mediators and enzymes, so pro-inflammatory cytokines, cyclooxygenase 2, are markedly increased. So these are inflammatory mediators, they're markedly increased in the lamina in early stages of sepsis-induced laminitis, and may injure the lamella or the laminae, and cause dysregulation, leading to loss of attachment. Hypoxia and ischemia, so that is due to a change in the blood flow, is possible. It's possible that they may play a role in the dysfunction in sepsis-associated laminitis, but it appears to occur later in the disease process. Laminitis, this type of laminitis is often of rapid onset, more severe and more difficult to manage than endocrinopathic laminitis. So grain overload refers to the overconsumption of carbohydrates. So a pony getting into a feed room, eating a sack of feed. This causes a change in pH in the horse's stomach and intestine, which disrupts the mucosal barrier in the GI tract, leading to absorption of toxins and endotoxemia. The pathway is thought to follow a similar pathway to sepsis-associated laminitis. Supporting limb laminitis occurs in the contralateral limb, so the opposite foot of a horse with a severe unilateral limb lameness that persists for several weeks. So, for example, a fracture or a very complicated abscess. The equine hoof is over-engineered, so it should be able to withstand this mechanical load. At gallop, the forces that go through the lamina are 3 times the weight, 3 times that of the horse's body weight. Therefore, the hypothesis is that supporting limb laminitis is caused by a change in blood flow to the weight-bearing foot. When the foot is fully loaded, vascular filling in the lamella dermis, so the lamina, is significantly decreased or absent. In experimental studies, under conditions of moderate load, the arteries that run down the back of the navicular bone are occluded, and at the top of the pastern, so the flow to the quarters and the heels is markedly reduced. Blood flow to the other regions of the foot is relatively unchanged. Under heavy load, so when the fetlock drops into its suspensory apparatus, the arteries at the back of the sesamoid bones, so where you would feel for a digital pulse, these are completely occluded and there's no filling of the vessels around the coronary band. Endocrinopathic laminitis. So in this group, we have equine metabolic syndrome, pituitary pars intermedia dysfunction, which is called PPID or equine Cushing's disease, and glucocorticoid administration. About 90% of all laminitis cases in the UK have an underlying endocrinopathy, so a change in their endocrine function. This is a little set of data from Liphook, and there are 177 cases of horses with laminitis, and 35.9% of them had a high ACTH, so had PPID, and within that group, the majority of them also had a high insulin. The other horses, so 43.6% had high insulin recorded from a post-in-feed glucose test, but a normal ACTH. So these are our EMS group, and 20.5% had a normal ACTH and a normal insulin. Within the group that no endocrine abnormality was detected, it doesn't necessarily mean that they are completely normal. It may just mean that they need further testing. So possibly a TRH stimulation test or looking at their adipokines. So our main focus with endocrine laminitis is hyperinsulinemia. With the EMS group, whether it's lack of exercise, genetics, obesity, they all come under the same equine metabolic syndrome label. PPID, these horses also can have a hyperinsulinemia. And also another factor would be a high intake of non-structural carbohydrates. Then the insulinemia leading to laminitis. So how does eating grass cause laminitis? The first theory was that disfermentation of sugars, so abnormal fermentation of sugars, upsets the mucosal barrier and the colon, leads to absorption of toxins and laminitis. But more recently, we think that the absorption of glucose leads to hyperinsulinemia and laminitis. So the traditional view is less plausible, because if you calculate the amount of non-structural carbohydrates ingested per kilo per hour of quite a greedy pony, quite a greedy individual on good grass, it doesn't come anywhere near the amount of non-structural sugars ingested to cause hypothesis number one. So it's like, but this amount is very much within the range that can cause hyperinsulinemia. So equine metabolic syndrome is not a disease, but rather a collection of risk factors for endocrinopathic laminitis. EMS is associated with inappropriate blood insulin levels, so insulin dysregulation, with a combination of increased fat deposition and reduced ability to lose weight. The key features of EMS: insulin dysfunction, hyperinsulinemia leading to laminitis. When these horses consume a meal high in specific carbohydrates, they produce a greater than normal tissue response, a greater than normal insulin response. Part of the syndrome is whether there is tissue insulin resistance, which means that we have high glucose circulating, leading to higher insulin production. Most horses are obese, but not in all cases. They have crusty necks and fat deposition on the ribs and tailheads. So genetics, whether there is a thrift gene, more ponies, Morgans and Arabs are overrepresented. Genes contributing to this phenotype were likely to be advantageous for survival in the wild during periods of famine by enhancing feed efficiency, i.e. the breed having to survive on the side of the mountain over winter. But this is not how they live now. Most of them are very pampered. Often grazing is the final trigger factor, but some individuals can develop laminitis without even having access to grass. So obesity, this can be generalized or just have regional adiposity, so like a crusty neck or fat around the tailhead. The above three factors make an individual more likely to have laminitis, more likely to have EMS. There is also the lean EMS phenotype. So we diagnose EMS by history, signalment, so looking at the type of pony, clinical signs as well, whether they are possibly a little bit chubby or have a history of laminitis. So the clinical test that we use would be an oral sugar test, and that we would give a horse 0.45 mils per kilo of a Caro Light syrup and take, after they've been sort of fasted overnight, take a blood sample at 0 just before we give the Caro Light and 60 minutes after. And the results of insulin, they should be less than 100, results of insulin over 110 at 60 minutes would indicate insulin dysfunction. The insulin tolerance test, so that looks, the insulin tolerance test, you would inject a horse with insulin and take blood samples for glucose at 0 and 30 minutes. If a horse is insulin resistant, the second blood glucose concentration does not decrease to 50% or less of the baseline glucose value. Adiponectin is a adipose-derived hormone with anti-inflammatory and insulin sensitizing action. Low concentrations of adiponectin are identified as a risk factor for future laminitis. So how does hyperinsulinemia cause laminitis? The exact mechanism is still unknown, but the current thinking is that insulin may act on vascular insulin receptors, possibly leading to vasoconstriction. There is also receptors on the lamina, the epithelial insulin growth factor 1 receptor, which could lead to altered cell division and then leading to impaired attachment of the lamina. The Cushing's disease, pituitary pars intermedia disorder is yet another name for equine Cushing's disease. The pituitary gland is found at the base of the brain and it produces hormones in response to signals from the hypothalamus. The pars intermedia is a part of the pituitary gland which functions abnormally in PPID. In horses without PPID, this part of the pituitary gland is relatively inactive. In PPID cases, the inhibition of the pars intermedia is lost, but the cause of this isn't exactly known. The loss of inhibition of the pars, The loss of inhibition of the pars intermedia leads to overproducing of a number of hormones, including ACTH, which is the hormone we test for. Clinical signs, a change in behavior, lethargy, delayed shedding of coat or a curly coat, muscle atrophy, regional adiposities, having fat pads above the eyes, potentially crest around the tailhead, infertility, laminitis, exercise intolerance, polyuria and polydipsia, so that's increased drinking and increased urination, recurrent infections, mammary gland secretions, so producing, well, not necessarily producing milk, but sort of a watery liquid, parasitism, so maybe your horse always having a high worm egg count, tendon and ligament laxity, and weight loss. The testing for PPID. So we look at the basal ACTH. So we take one single blood sample, and that the normal range varies with the season. And we can also do a TRH stimulation test. So we administer this IV. And so this is one of the hormones above ACTH. So we take a blood sample for ACTH at 0 minutes and 10 minutes, and horses with PPID will have a more exaggerated increase in ACTH. PPID and laminitis. So laminitis in uncontrolled PPID cases is often recurrent. How PPID causes laminitis isn't fully understood, but it's attributed to cortisol, CLIP, and other hormones antagonizing insulin, leading to hyperinsulinemia and then laminitis. Insulin is a good prognostic indicator for horses with PPID. If they have insulinemia, they are more likely to then get laminitis. Glucocorticoid-induced laminitis, so steroid-induced laminitis, is a rare complication of steroid administration. It's thought to have an endocrine cause, but the mechanism isn't fully clear yet. So that can be whether it's joint medication, long-term use of steroids for equine asthma, or inflammatory bowel disease. Pregnant mares. It's not currently fully understood why pregnant mares seem to be at an increased risk of developing laminitis. Current proposed theories is that the endocrine changes associated with pregnancy increases the mare's risk of developing laminitis. So in women, we know that pregnancy alters the glucose and insulin dynamics. Insulin sensitivity is decreased by 60% during pregnancy in women. In human bovine and rodent studies, it is documented that at the time of birth, the insulin relaxin and their two hormones cause the connective tissue in the birth canal to loosen. At this time, cows also experience weakening of the suspensory apparatus in their feet, and it has been hypothesized that brood mares may experience the same connective tissue laxity, increasing the risk of laminitis. This is just another case study, which is a combination of pregnant mares and support limb laminitis. Unfortunately, this mare had an abscess, which took a long time to come out, and I actually blocked the foot to debride the heel area where the abscess had popped out. And when I'd blocked the foot with the abscess, I noticed that she was also a little bit sore on the other foot, but you wouldn't necessarily have noticed that without removing the pain of the other foot. And so we placed pads. There weren't, I don't think there were radiographic changes at that point, but we placed pads, and unfortunately you can see how this has then developed. So there's a combination of laminitis in a pregnant mare and also in the supporting limb. So the pedal bone has rotated away from the hoof wall. You can see a gas shadowing here. So take home messages. Do not underestimate laminitis. It is very painful. I think you will also realize that we still have a lot to learn about laminitis, and there is a lot of research going on as we speak. Prevention is better than a cure. Be proactive, not reactive. Try and stop your horse getting laminitis rather than actually just treating the laminitis itself. So by identifying the risk factors. Endocrinopathy is detectable in most cases of laminitis. It's just working out what we're dealing with. And hyperinsulinemia is a very recognized and well documented causal link for and with laminitis. So thank you very much. Do I have any questions?
Thank you, Emily. That was a very interesting and informative presentation. I think laminitis is probably one of the worst things that horses and ponies can ever suffer from. I think it's the most painful, horrible thing for them to have to undergo. We've got a few questions. One question which was interesting was somebody raised the point that they'd read an article where a horse had had an injury to its hoof capsule, and basically the hoof capsule had regrown, and they were questioning why it is that when a horse has had laminitis that they can't regenerate a hoof that will support them for the rest of their life. Have you got any thoughts on that?
I think if a horse is its hoof capsule, it will then be growing down more normal. Or above the injury, and that will grow down. But they haven't actually injured their lamina. So weakened, it takes and also help from your corrective trimming to help them fall. But they never will probably have never will have a normal foot. But it's the horses that have damaged their hoof capsule. They haven't actually injured their lamina. Unless Natasha has anything to add.
Do you think that there's, it's probably more likely that it's the underlying causes that are stopping the production of the hoof capsule and causing the persistent laminitis that's the issue, whereas when you've got an injury, the injury's happened, it's gone, and you haven't got the causal situation anymore?
Also, imagining that once your horse had laminitis, we would be looking at controlling underlying risks.
So you mentioned earlier on about, or in your roundup slide about prevention is better than cure. What tips have you got in terms of prevention? What would you advise somebody if they recognise that their horse has got some risk factors for developing laminitis? What would be your tips? What would be your top tips?
Well, it's working out what risk factors are. If your horse,
hang on, is your microphone functioning properly? I'm not. You can hear it clear. Okay, just try again.
Can you hear me? Yep.
Yeah, try again.
So if it's working out what those, and it's very different for all the risk factors and controlling those risk factors. I know I did have a slide in controlling the risk factors where I believe Natasha is going to be talking about these effects still happened.
Okay. I just wondered what your true thoughts were. You mentioned joint medication as a cause of laminitis. What do you really think the true incidence of that is? Because obviously I treat an awful lot of horses' joints, and it's a common question that people ask me. is their horse at risk of developing laminitis when I medicate its joints? What are your thoughts on that?
I think if a horse doesn't have or has few of the risk factors associated with laminitis, has any of the risk factors associated with laminitis, so the population you look after, Ed, are younger, generally very fit. They're unlikely to be fat or obese, and they are in a healthy.
I think there is something wrong with your microphone. I don't know what's going on. Maybe try disconnecting your earbuds, because people are now saying they can't hear you, and I can't hear you.
Is that any better?
Speak.
And anyone?
Yeah, try that.
Okay. So the population of horses that Ed is looking after they're very fit individuals. They wouldn't be obese, so they would have a low risk of getting laminitis. It's the only case I have had is when it was a native pony that he had a slightly chubby native pony that had his joints injected, and he developed laminitis. So I think the incidence of it is low, but potentially if you're medicating maybe an older horse, you might want to test them for Cushing's or look at whether you think they're whether they're insulin dysregulated as well, and whether potentially with some horses I have medicated them but not with steroids, medicated their joints with other products, and then they've been able to come back into a higher level of work, they've lost weight, and then if I need to treat them again, I've then treated them with steroids, and they've been fine.
I mean, in my experience, I've treated literally thousands of horses' joints, and I've only ever had 3 horses develop laminitis, and all of those were horses that, unbeknownst to us, suffered from Cushing's disease. So now my protocol would be, once they reach a certain age, or if I look at them and I'm concerned about them, I will test them for Cushing's before we even consider treating their joints.
Yeah.
16 is actually my cutoff. I would test anything over the age of 16. I'm just looking through the other questions. Can you just explain the difference between sinking and rotation again? That's just a nice simple question that somebody's asked.
So sinking is where the pedal bone sort of descends towards the sole, whereas rotation is where the pedal bone rotates away, and you get that angle of angle between the hoof wall and the tip and the pedal bone. So they're sort of radiographic differences.
Okay. Another nice quick question. You mentioned that fertility can be affected by having Cushing's disease, and the question is that redeemable?
I can think actually of one mare that I think you potentially dealt with, Ed, and once she was started on Percent, she then had continued to have a number of foals, so I think yes, it is redeemable.
Yeah, certainly. We've had several mares over the time that we've done, particularly with embryo transfer, where we've identified that they've got Cushing's disease, or we've had fertility issues, and then we've looked at them and found that they have Cushing's disease. We've then started treating them with Presend for Cushing's, and we've then started to harvest embryos from those mares. So yes, to a certain extent, it is redeemable. What other nice questions are there? Yeah, there's a few questions that have come through which I think really are probably more appropriate for Natasha. Okay, I think we'll thank Emily there for her talk, and I think we'll hand it over to Natasha, and we'll enjoy listening to her talk. Thank you very much, Emily.